clinical oncologist. Okay, so welcome everyone. So my name's Louise Hannah and I'm a consultant clinical oncologist in Cardiff. I'm also the Medical Director for Education and Training in Clinical Oncology in the Royal College of Radiologists. So this is our webinar on why we feel that oncology is the best job in the world and how to apply for clinical oncology training. So we're really pleased that you've been able to attend and that you're considering oncology as a future career. Could we have the next slide, please? So just to say that this webinar will be recorded and it will be available on demand 5:30 until 6:30 p.m. And some of the panel will remain on the call afterwards, after 6:30, to answer any specific questions. And we will provide email addresses as well to contact the presenters for any follow-up questions. So to go over some ground rules, we do ask that you turn off your videos and remain muted during the webinar. And if you have any questions, please do type them into the chat box and they will be replied to in the chat. And Dr. Tom Rokes, our Vice President, will be keeping an eye on the questions for us. So later in the webinar, we're going to have some presentations from our trainees. But first of all, I'd like to invite Nikki Thorpe, who's our Medical Director for Professional Practice, to chat to three of our trainees, Alex, Mariam and Abby, about what attracts them to clinical oncology. Thank you.
Thank you so much, Louise, and thank you to everybody who's online, who we can't see, but we know you're out there. It gives us great pleasure to be running this webinar because we really do believe that oncology is the best job in the world, and we really hope that you'll be convinced by the end of it, if indeed you aren't already convinced. So my name's Dr. Nikki Thorpe. I'm a consultant clinical oncologist. I work at the Christie Hospital. And my job is very unusual for clinical oncology because I just treat children now. But for most of my career, I've treated adults with breast cancer, with chemotherapy and radiotherapy, and also adults with upper GI malignancies. But now I just do radiotherapy for children. And I think that just illustrates how your career as a clinical oncologist can evolve over time. I'm the Medical Director for Professional Practice for Clinical Oncology for the Royal College of Radiologists. And rather than listening to me talk about my career, what I'd really like to do is give the floor to our trainees and let them tell you why they are oncologists, why they chose oncology, and just talk about what they do and why. So firstly, I'm going to turn to Alex, our trainee, and ask you, Alex, why did you choose oncology? And if you'd also like to say a little bit about where you work and what you do, and then answer my question about why oncology. Thank you, Alex.
Yes, absolutely. Thank you. Hi, everyone. Thanks for joining us this evening. My name is Alex, and I am a clinical oncology registrar working in North London at the moment. I currently work at UCLH, where I'm working with the neuro-oncology department. So treating a wide range of patients, different ages, with photons and protons. It's all very exciting. And I love my job, which is why I am here this evening to talk to you all about it. I think to answer your question, Nikki, I think one of the main reasons why I applied for clinical oncology was an appreciation of the fact that I get bored very easily, and that clinical oncology really offers the greatest variation in any medical speciality that I can think of. If you think about the work that we do, it's outpatient based, there's radiotherapy planning. If you are keen to get involved in procedures, there's brachytherapy. If you like acute medicine, there's the acute oncology service as well. And I think there's something for everyone in clinical oncology. And as a trainee, you get to experience all of that as you go through training. So I don't think I can think of a better job to be doing, really.
That's a great answer. And the other, I think, thinking about the range and the breadth of what we do, there's the technical aspects of radiotherapy, which have evolved so so much over the past 10 to 20 years. It's unrecognizable compared to when I started. But there's also the psychological aspects, the communication aspects. We have to be good at the craft of radiotherapy, but we also have to be exemplary communicators as well. And not everybody can be good at everything, but I think oncology, you can really pick and really develop all those different aspects of being a doctor. Absolutely. Thank you. So going on to Abby, tell us what aspects of clinical oncology that you really enjoy. We've touched upon some aspects, but let's hear from you. Thanks, Abby.
Absolutely. Thank you very much, Nikki. Hi, everyone. My name is Abby Abiola. I am a registrar in clinical oncology, also working in Manchester at the Christie. To be honest with you, one of the main aspects why I love oncology is the people. I remember when I was an SHO, I guess I had a very systematic way in terms of how I wanted to choose my specialty. I knew I didn't want to do surgery. I didn't want to do this or that. I sort of narrowed it down. And then I thought, who out of my placement have I enjoyed spending time with the most? And it actually turned out to be the oncology team. So not just the doctors that I've worked with, from the consultant to the SHOs to the registrars, but also the nurses, also the radiographers, also just the wider team. And along with the people, professionally that I work with, also the patients. I think, you do really feel like you get a nice bunch of people working in in oncology and also coming to us as patients, funnily enough. So I think, to me, the people I work with professionally and the patients that I serve are the best part of the job, to be honest with you. Without going too much over what Alex has already said, I think the mix is wonderful for me. As Nikki said, I like some things more than others. So I like radiotherapy very much. I also like giving drug treatment, and I enjoy that I get to do both. But the good thing about oncology is that you can do a bit of everything, but you can also choose what you like to do a little bit more, and sort of focus on it to a great extent. So for me, radiotherapy is really good. I like drug treatment as well. I like being able to give new things because it's an evolving specialty. And related to that as well slightly is the fact that as an oncologist, you learn as a registrar across various different sites. So you go from your CNS rotation, you go to your gynae rotation, you go to your lung rotation. And so you really learn the principles of treating various parts of the body. But again, as you progress in the career, you can become even more specialized, which is really nice. So you can find one or two or even three specialties that you really like to, practice, and that can be, what your career is. And so for me, I have my special interest that I'm going to focus on in the future. So really, you do have a broad base. You're sort of a generalist in some respect because that's how you train, but then you can also get to the nitty-gritty and become more of a subspecialist, which I think is quite nice. So you kind of have the best of both worlds in that aspect. So there's lots. I'm definitely not going to cover it all, but I think to me, those are my top few reasons why I love oncology.
Thank you so much, Abby. Yeah, and thinking about listening to you, there's also the research, and we're very evidence-based. So if you are an academic, it's oncology is great. A lot oncology has evolved over the past 20 years because of the research, and so we've got this fantastic evidence base that we can use, but that continues. So even if you're not an academic and research isn't your main interest, you're always involved in pushing the boundaries, testing new things, and really improving care for patients as well. And I completely agree that the richest part of our job is the people. It's the people we work with, but it's really the patients. And having cancer it does something to a human being. Why that is, I can never quite put my finger on, but it's a profound experience, and you're sharing that very profound experience with people, whether you're curing patients, and we cure a lot of patients. I say, you're in a diabetic clinic, don't very often talk about cure, whereas we're always talking about cure, but also for those patients that you can't cure, there is still loads that you can do for them. And the art of oncology is often getting that balance about helping patients' symptoms, helping them live their best quality of life, in spite of the fact that they know that we can't cure their cancer. And that's a really profound aspect. So we're building this jigsaw of the technical side, the hands-on side, the communication side, and the interactions that you have with your patients and your colleagues. So it's a wonderful subject. It's the best job in the world. So going on to my final question, which is for Mariam. Not everybody wants to do oncology. And I think some people are dissuaded before they even consider it, because it possibly has a slight PR problem. So, Mariam, was there anything when you were applying for oncology, when you were thinking about doing oncology, that made you hesitate? And what would be your advice to anyone in the audience who's hesitating and thinking, actually, I don't know whether this is for me?
Yeah, absolutely. Thank you, Nikki. So I'm Mariam, and I'm a clinical oncology trainee also at the Christie in Manchester. There were two main questions I had before applying to oncology that I wanted clarified, or that I was a little bit hesitant about to start off with. So one particular one is the idea that oncology is a very depressing specialty. And I understand why I maybe thought that. As an SHO, you get a very skewed view of what oncology is, because you only see that 1% of the sickest patients who have, unfortunately, the saddest stories on the ward, but you don't see all the very kind of rewarding aspects of the curative side in everything else that you do in clinics, in radiotherapy and systemic treatments. So, and a lot of people don't know, and I didn't know this, is that radiotherapy is actually mostly curative, like you said. So it's actually like an alternative to surgery. It's a curative treatment, and it's lots of good news all around. So actually that was quickly put to rest, and that I was like, this is not the reality of it, and thankfully I get to give people good news every day. And the other thing that has made me hesitate is the rumor that clinical oncology involves a lot of physics. Now, I hate physics. I hate maths. That's not what I am. Probably lots of people feel the same way. And thankfully, that's not the reality of what clinical oncology is. So I use this metaphor. So if physics in clinical oncology is like cooking, all you need to learn how to do is to learn how to boil an egg. All the rest of the stuff with regards to the nitty-gritty of physics, there are specialist physicists you work with who do all that stuff. So all you need to do is do the fun bit, which is the planning, which is very nice and simple, and you don't need to do all the physics, I call it. So that's a rumor, and thankfully it is a rumor, because if I made it through so far, absolutely people would really enjoy it. And thankfully it's such a nice, diverse specialty. So all of these rumors were just rumors.
Thank you.
And that's it.
Thank you so much, Mariam. And I would absolutely agree. I think I don't know what my physics teacher, my A-level physics teachers are doing now. But if they could see me now, they would be surprised, because absolutely, physics and maths were not my strong subjects. But that the amount of physics and maths that you need to be a good clinical oncologist is not too much. If you are that way inclined, then you can really develop that. So again, there's that flexibility in the subject. Different people bring different things to the table. So absolutely don't be put off by the fact that this, if people think of clinical oncology radiotherapy and they think physics, and yes, it's really important, but again, it's a privilege to be working with physicists who, from my point of view, I think their brains are wired up differently to mine, and it's wonderful to have those discussions and learn things from these people who really do understand subatomic particles and big machines and things like that. So I absolutely. So that's all my questions. But I don't know if anybody anybody else on the call would like to say anything further that you think we may have missed about how great clinical oncology is as a career, Louise or Tom possibly?
I'm going to come
I'll
in.
put you on the spot.
Nikki, hi everybody. I'm Tom Rokes. I'm an oncologist in Norwich. I'm going to tell you about the patient I've just seen on the ward who epitomizes why this is a great specialty. So I've actually just been to see one of my patients, and in the bed opposite was a lady I treated for lung cancer and brain mets in 2005. So A, you can cure people even with nasty cancer. B, I've got no idea how to treat lung cancer now because I stopped doing that in 2010. So even as a consultant, your career can vary and change so much over the years that you do it. So not only, as Alex said, have you got the option to be almost a sort of surgical oncologist with brachytherapy or to do acute medicine, you can change that throughout your career. You can have a job that has different bits of that in it as you go through. So it's a hugely varied career. And C, there's that longevity in what we do. So it's a huge privilege in medicine to see someone and follow them through for months and years as they go through their treatment and out the other side. And oncology gives you that in a way that few things do, I think. Primary care does. But I think, to be able to see someone 18 years later and to know that you've done a good job and that they're okay out the other side is a huge privilege.
Absolutely. And sometimes you cure people that you don't expect to cure and you can't say why. So it's just biology, and it's great. Louise, is there anything you'd like to add?
Yes, thank you. So carrying on from the themes that have already been raised, really, I think for me, it's the combination of that holistic care combined with that precision and care and detail that goes into each individual patient, because individual treatment, because nobody has the same treatment. And also the continuity of care. So we really get to know our patients. We really, I sometimes think I'm the only person that really knows exactly what this patient has been through, and to have that and it's such a privilege to sort of be a partner with the patients in this such critical and important part of their life. So I think that for me is one of the drivers, really.
Yeah, thanks, Louise. I think we absolutely all share those sentiments, and I think that aspect, which is so important for all of us, is not immediately what people think about when they think about oncology. And one of the things I pick up when medical students sit in the clinic with me, they all say, I thought it was going to be really depressing. And yet it's not at all. It's less depressing than most clinics, and everybody's laughing. This is very strange. But this is all, we're not just saying this just to convince you to do oncology. This is our genuine experience of our work, and I think that's what makes it so wonderful. So thank you very much, everybody. I'm going to go on mute and switch off my camera now to allow you to go on to the next section. So thank you so much.
So thank you very much for that conversation. And I just saw popping up in the chat about what's the role of immunotherapy in oncology. And I think that's another thing as well, just the ability to be on the cutting edge of science, the ability to take part in clinical trials, because obviously immunotherapy is a very relatively new treatment. It's getting more and more indications at the moment. And it's something that's gone into a lot of different tumour sites, and we're using it more and more, and it really is, a whole almost sort of specialty in itself. So yes, we're using it a lot, and we anticipate using it more and bringing it forwards and forwards in the treatment pathway as well, from sort of metastatic disease to adjuvant disease. So what I'm going to do now is I'm going to ask Alex and Marion, please, if you could just do your slide presentation, and you're going to talk about clinical oncology and what it involves, and a little bit about how to prepare for it as well. So thank you very much.
Thank you, Louise. So Alex and I are co-chairs of the Oncology Registrars Forum, and we're clinical oncology trainees. And we're going to talk a little bit about the clinical oncology training program and all the practicalities and why it's the best program in the world. Next slide, please. So just to give you a bit of background about each of us, we come from very different backgrounds and we've had very different journeys to get to where we are now. But yet we have reached the same goal and we love our jobs very, very much. So, for example, I qualified in 2016 overseas in Jordan, and I've pretty much been involved in oncology in some way or the other in every year of my life. So of my medical training. So I did a bit of oncology work in Jordan, and then as an F2, I worked at St. Luke's Cancer Centre in Guildford, then worked at the Royal Marsden during my internal medical training, and then finally now I'm at the Christie in Manchester doing my clinical oncology training, where I'm 80% less than full time, and I'll talk to you about that a bit later. But yeah, that's my story, and I'll let Alex tell you a bit about his background.
Yeah, so mine's very different to Mariam's. I graduated in 2014 from University of East Anglia and stayed in Norfolk for my foundation training. I then went down to do core medical training in London, and by the end of this, I still had not done a single job in oncology or come across it much as a speciality. I was completely unclear why the RCR was involved in oncology at all if they were radiologists. I then started as a locum medical registrar in Norwich again, and from then got talking to people and took a job as an acute oncology fellow. Did 2 years there, absolutely loved it as my first oncology experience, and applied to clinical oncology specialty training, and then come back down to London again. So I've yo-yoed a bit, and here I am nearly 10 years after graduation, finally doing what I love. And yeah, it's really enjoy it. There's a picture of UCL, there's our proton beam center, which is heavily advertised. And yeah, together we are the Oncology Registrar Forum co-chairs. If we go to the next slide, I'll tell you a little bit about what that is before I let Mariam carry on. So we are a group of trainees, one representative elected from each region. You can see some names which may be familiar to you there. And essentially our role is representation within the college. The RCR is incredibly supportive of trainees throughout their training, and the ORF is just one way that is enabled. So we represent trainees within the college, we sit on different boards and help with guideline and promotion. We communicate between the college and trainees and ensure that quality assurance protocols are and get involved in the quality assurance processes of the college as well. So it's really interesting. It adds a bit of variety to our work as well, and it's something that you would be encouraged as a registrar to get involved with as you go through your training, the training which Mariam is going to talk about now.
Yes, so if we go on to the next slide, I will start to tell you a bit of the practicalities and logistics of clinical oncology training. And to start off with, to get started with clinical oncology training, you need to apply. So just a brief overview of the application process. So you're actually eligible to apply to clinical oncology ST3 after only 2 years of internal medical training. So if you may or may not know this, but internal medical training is actually 3 years in total, but you're technically allowed to leave after 2 years to apply to things in a round 2 specialty, and one of those is clinical oncology. So that's really was a plus for me at least. And the application process is very, very simple. It's an online application through Oreo, which is a application website. The round 1 applications open in November of each year usually, and round 2 open up in July. And it's just a simple form that you fill out, and then you have to give yourself a score, a self-assessment score based on these criteria to the right that you see. So basically things like postgraduate degrees, presentations, publications, teaching experience, quality improvement projects, etc. Don't worry if you don't have them all or don't have many. You really don't need many. It's nice to have them, but it's just to just score yourself to get you through to the interviews, which are until this point usually held virtually on Zoom. So after your interview, you get your ranking, and hopefully you get a job in clinical oncology and you get started. And I've not put the details of all these points because I know probably some people would want to have a bit more of a a detailed version of this, but it's all on the HEE website, or if you just Google clinical oncology ST3 self-assessment, it will give you the full breakdown of the points, just to give you an idea. And then next slide, please. So you've now made it into clinical oncology training, and this is what the pathway would look like once you've started. So starting off with ST3, that's your first year, and that's your oncology common STEM year. Which basically is almost like a general oncology overview. It has a bit of acute oncology involved as well. This is the year that we share with our medical oncology trainees. So, you know, it's more of an overview of oncology, and then you move on to the more in-depth radiotherapy and systemic treatment part of it in the rest of your training. You've got the FRCR exam as part of your training that you need to complete to be able to become a consultant. So you're eligible to take your Part 1 exam, usually around ST4 year, and then your FRCR Part 2 exam, usually you're eligible to take it around your ST6, between ST6 to ST7. And I'll talk a little bit about that, about exams in more detail later on. But once you've finished your ST7, you then CCT and you become a consultant. But all throughout your training, you have the opportunity, if you wanted, it's not mandatory at all, it's just an extra thing if you'd like, to go out of program. So all of these OOPs that you see at the bottom here is out of program experience, out of program training. Basically, you can, if you decide you want to do a fellowship in something very specific in radiotherapy, you can do that, and that actually counts towards your training. You can even go to a different country. So I think Abby, my colleague Abby, if I'm not mistaken, went to Austria for a year, which was lovely. And you can, even if you decide, you know what, I just want a break to be able to travel or do what I want, you can do that as well. So there are lots of different ways you can you know, change up your training. If you're interested in academics, you can apply for research or like a PhD. So it's all flexible, and you can do that at any point during your training. Next slide, please. The dreaded exams. So nobody loves exams. I mean, as medical doctors or medical students, you probably have to go through lots and lots of exams, and we, you know, it's not the nicest thing ever. But you will not be this confused meme lady. So this won't be you, because, and if we go on to the next slide, I'll tell you why. You will have lots and lots of teaching and courses, and I mean a lot. So as part of clinical oncology training, and this is all funded by your by your training program, you have extensive courses to teach you about literally everything from the basics of cancer biology to radiobiology to physics and all these like little bits. So you have extensive courses, and those vary in terms of how they're structured in every region, but they're always very extensive. So for example, some regions have like 1 day off a week for a whole year, and that day is for a course, and other regions have like full blocks of a weekly teaching throughout the year. So you'll get lots and lots of study leave, basically. Not only that, but you get study leave for self-study to help with revision for exams. And on top of that, you get your regional teaching days and you get your local teaching. And the RCR website has lots of learning modules and videos. And there's a question bank for the Part 1 exam as well. Adding on top of that is that every single clinical oncology consultant and senior reg colleague that I've met has always been more than happy to kind of go through things and teach you. And not only that, but you've got lovely radiographers and physicists who are always happy to teach in your local hospital. So basically, you've got lots and lots of support. Next slide, please. I've touched on this before later. I don't know if you could see this man at the right side of the screen there, but that's meant to be Albert Einstein, basically. But basically, physics exam, like I said before, it's not physics the way you would normally imagine it. So not, you know, we're not going to turn you into the next Einstein. You'll never get to see any of these very complicated equations. It's actually more like the picture to the left, where you learn about what radiotherapy planning is, a little bit of the science behind that and how it affects, you know, cancer cells and how the machines work a little bit. So it's all very kind of simple and relevant to clinical aspects rather than all these like complicated equations. So next slide, please. So what does a typical day in the life of a clinical oncology reg look like? So I've put in my current work timetable. So like I've said before, I'm less than full time, and I do less than full time 80%. So I'm off 1 day a week. So my week typically looks like I've got a bit of planning for some sessions. I've got some admin, some clinics, journal club and teaching, and I've got MDT radiotherapy cover. So a bit of a mix of everything, but it's a very kind of nice spaced out schedule, and I have 1 day off a week. But in addition to like the regular schedule jobs that I'm meant to be doing, I also have extra time to do lots of other things that I enjoy. So for example, Alex and I are both co-chairs of the ORF, so I have some time to do that, which is very fun. And I'm the RCR trainee learning lead. I also have time to get involved with clinical trials and do some research projects. I have time to do audits, and I have time to teach junior doctors and ACPs. So lots of extra time to do things that you love, if that's what you're interested in. Next slide, please. So yes, all these stock photos are me, but basically this is what a typical day would look like. So come in the morning, I'd have my morning coffee, and then I go on. If you see that picture in the middle there, that's me doing some drawing around bits of the body on a scan image.
Contouring, Miriam, contouring.
Yes, sorry, the technical term is contouring, not drawing, but basically I'm outlining all these, or contouring all these anatomical bits on the scans, or the cancer bits, and then I'm catching up on emails, that picture to the right there, and I'm very happy doing that. And then I am happily enjoying my lunch, because in clinical oncology training, which is something I actually didn't have before in my medical career, there's always time to have lunch, because mostly it's, very little stress. We've got lots of time to do things. And then finally, I'm in clinic in the afternoon. So that photo of me with this lovely lady there who looks very happy because I've told her that she's been cured of her cancer, basically. And like I said before, remember, radiotherapy is mostly curative. So you see a lot of that in clinics. And next slide, please. So just briefly about what on-calls look like for us in clinical oncology training. So Alex and I have the advantage of knowing what the rest of the UK does, because we chair the ORF, so we see what people around the country have in terms of on-calls. And most UK regions have non-resident on-calls overnight, which means that you're basically overnight, you're at home, but you may get calls for advice, and it's usually, not very complicated. So that's a really, really huge plus for work-life balance. The on-calls are usually infrequent, and they're very well supported. So consultants are always happy for you to give them a ring if you're not really sure what advice to give. So all in all, a very kind of nice and kind of well-supported environment, even in a on-call shift, which is great. Next slide, please. And finally, the best part about flexible training is the fact that you can be less than full-time. So a full-time trainee already has great work-life balance, as you've seen in the sample schedule there, but you get even better work-life balance, and you don't actually need a reason to apply for less than full-time if that's something you want. So for example, for me personally, I applied for less than full-time because I just wanted an extra day to enjoy my life. Traditionally you used to need to have a reason, like childcare duties or carer duties, and I don't have any of that, but I've been fortunate enough as part of clinical oncology training to be applied just because, basically. And it's great. It really lets you enjoy your life and give you time to do the extra things that you want. So you can apply to less than full-time at any time during your training. It's a very, very simple process to apply. I literally filled out a form and it was approved the next day, and that was it. It was the start of my next rotation, and I got to work 4 days a week instead of 5. You can also mix it up for better pay. So for example, you can do 80% less than full-time, but do 100% of your on-calls, because they're not frequent anyway. So there's lots of flexibility there, and it's all very, very, very well supported. So you've got incredible support from your training program directors and the Royal College. And it's, if that's something you want to do, it's, you know, it's very easy to get involved in it in training. And that's my bit. I'll let Alex move on to the next part, which is all the fun stuff about being a clinical oncology reg.
Thank you, Mariam. I am going to try and summarise what's great about the job now. I think Mariam's picked up most of my points already, but I'm going to try and pick my top 5 for you. I do go a bit tangential because I did think it was hard to summarise in 5 points, but try and bear with me. If we go to the next slide, I don't think we can push this point enough about how varied and diverse the job is. There is no opportunity to get bored within clinical oncology. So here's what I've done in my training so far. I've done 2 ST3 rotations in Romford, doing uro-oncology and lung, 2 ST4 rotations at UCL, gynae, breast and GI, and I'm now an ST5 in neuro-oncology. And I put my work plan in there because I think it just shows the variation in the week. There's no day doing the same thing. And it generally is exciting getting up in the morning, and I still enjoy going to work, I'm sorry to say. And I did ask some of my colleagues whether they get excited as well, and most of them do. That is a lot of words on my work plan, but if I have a look at actually what that involves, if you go to the first slide, you will be in MDTs, and a lot of the time when you're in your medical training, if you ever have been to an MDT, they can be quite dull. You sit in the back, you fall asleep, you look at your phone. Actually, when you're a clinical oncology trainee with some good supervision, and once you are educated and you know the patients that you're talking about and the cases that are being discussed, MDTs are genuinely interesting. You learn a lot from them. You learn a lot from surgical colleagues and from radiologists and pathologists even. I really enjoy them now. I think most of the oncology trainees that I've spoken to do as well. I don't think I'm an anomaly. Then I personally enjoy getting up on a Monday morning and going into theatre and getting scrubbed up and doing some intrauterine device insertions for brachytherapy in my gynae oncology rotation. I think it's important to say that if you enjoy procedures, you can get involved with them. But likewise, although an understanding of the concepts and what they involve is important for your training, if you don't like that, you won't be forced to by any oncologist, by any consultant. I think my gynae oncologist asked me at the start, do I want to get involved, yes or no? Do I just want to be taught how to do it, or do I want to get my hands in? And obviously I said yes, then get me involved. Then the next day, if we go to the next slide, so there's Oberlin Cancer Centre where I have my outpatient clinics, and that is an enormous part of our job, is running clinics, and they are very rewarding. I think we've said it multiple times already before, but they are generally nice clinics. You are telling a lot of patients that they have been cured. If not, you are helping them and you are giving them an intervention which will help them. I think Nikki said something important there that, earlier in the webinar, where she said that she laughs a lot in clinics. Oncology clinics are not depressing. I laugh far more than I cry with my patients in clinic. So they are generally nice experiences. And then there is the ward as well. Again, you might be more acute inclined than other people. You might like your acute oncology job and want to get involved in it. I certainly do. I do like a bit of acute medicine at least once during the week. So there is ways to get involved with acute oncology as well, managing takes and deteriorating patients on the ward. And then next slide. Mariam's already said the extensive training that you get in teaching, because a lot of these topics that you'll be learning about for your registrar training will be new. Radiotherapy planning, the bits of physics, the bits of pharmacology that you're going to need for your exams and your training, they need to be taught to you. And so I took a day out each week to go to the ICR course in my first year. I then took a second day out every year in my second year of training, and I'm now looking to complete a master's in that. So there are plenty of education opportunities as well. If we go to the next slide, one of the things that I haven't spoken about in the variety of the job is the radiotherapy planning, and this will constitute a very large part of your work when you do eventually all apply for clinical oncology training. So there's lots of contouring involved. It looks very complicated. It isn't. You get taught it. It's exciting. I think I'm going to disagree with Marion at one point. She said it was simple. Sometimes it can be very complex, but actually they're the ones that are really interesting to get stuck into. Sitting down with your consultant with a cup of coffee, of course, and talking through the cases, looking at the histology, looking at the preoperative imaging, and putting it all together to create a treatment plan for a patient is very rewarding. I think it's an aspect of the job that we all enjoy. Please do, if you haven't already and are interested in doing clinical oncology, get in touch with someone and go down and see some radiotherapy planning, and ideally put some pen to screen as well, because you will find it enjoyable and sometimes relaxing as well. It's a nice way to spend the morning. As well as radiotherapy planning, in clinical oncology, we are also involved in systemic treatments, which is on the next slide. And so I think there are a couple of questions coming in the chat about what the difference between a medical oncologist and a clinical oncologist is. In clinical oncology, we specialize in radiation therapy treatment as well as systemic treatments for cancer. That is another variation. That's another thing that you can offer patients when they come to clinic. It's part of the reason why I chose to do clinical oncology. You get a bit of everything. Medical oncologists are trained in systemic treatments. They're encouraged to go into research with novel drug developments, for example. There's no reason why you can't as a clinical oncologist too. There is sufficient training as such, and there are opportunities too as well. Next slide. And I think this is one of the most important things, and it's the people that you come across in training. So there's a few pictures which I've unconsensually put up on the presentation of some colleagues, some former colleagues. On the right there are some friends that I've made through doing the course. These are trainees, not just in my region, but from other places in the country as well. You get to meet nice people, speak to your clinical oncologists in your hospital. We are all generally nice. With most of us are normal. We can talk to you. We can explain what we do and why we enjoy what we do as well. And every year we as registrars meet up at ATOM, the annual trainee oncology meeting. And it's a conference run over a weekend, very educational and also very fun as well, with dinner and drinks in the evening. So the colleagues are very important to the job because they're going to be the reason why you enjoy going to work every day. But also, if we go to the next slide, it's already been discussed that the patients are really important as well. And sometimes it can sound cheesy when specialities talk about why they want to be involved is because they're patients. It's genuinely true in oncology. We see such a diverse range of people throughout all stages of their illness. It is incredibly rewarding to be looking after a patient with cancer. They're normally very grateful. You have things as a clinical oncologist which you can offer them to help them as well, whether that be to cure their cancer or palliate their symptoms. We can do things to help with the treatments that we have. Next slide. The next one is your future career. So I think what's really important is, as a consultant, being able to decide what you want to do. And I think that I look at consultant colleagues and I see that they are able to do this. So not just necessarily with what site specialty they are working with, but how much clinical work they want to get involved with, how much training as well. There's opportunities to get involved with the college and management within your department as well. I've put artificial intelligence in there. You know, our jobs are not going to be taken over by AI. We're going to be right now at the generation where it's advancing, and to be a part of that is exciting. So there's ways that you can get involved in technological research. I've accidentally put private work on there twice, sorry, but that is important to some people, and there are opportunities within oncology to do that too. And research as well. I'd never thought that I would want to get involved in research. I've always been very clinically minded. Ever since starting my MSc, I've got a bit more interested, and just today was talking to one of my consultants about potential plans for MDs or PhDs in the future. We shall see where that goes. So I think there's so many things that you can bring into your job as a clinical oncology consultant. I don't know why anyone would not want to do it. The final point on my last slide is, I initially called this work-life balance, but I went on a bit of a different thought stream, and that's about the sustainability of the career. Is this a career where I'm going to be able to be a consultant in for 20, 30 years? There's always going to be work for us within the NHS. That's incredibly important and something to consider. There's nothing that's going to take over our role as oncologists. We need trainees and consultants as well. So there are going to be training numbers, and there are going to be consultant jobs at the end of it for you if you take on training. Less than full-time work, Mariam's already spoken about, but there are opportunities in that as well. Some people are fans of a working from home or a hybrid model. Many job plans as a consultant clinical oncologist will have an aspect of working from home. It's not important for me, but it is important for some. But I think that it just exemplifies how diverse the job can be, that parts of it, NDTs, can be built into your life to make it achievable and work around you. The on-calls are manageable and the ward rounds are manageable. We're not going to do any bashing of other specialities here, but I know that when I was working in other acute specialities or ward-based specialities, I couldn't see myself doing post-take ward rounds for the rest of my life. So please come and talk to us. The trainees, the consultants that you have in your hospitals are approachable, and we are generally happy, and we will be happy to share that with you as well and explain why we are and why you should come and join us. And with that in mind, I'm going to share on the next slide my email and Mariam's email. They will be at the end as well. Please do note them down. Please do ask us for advice or any opportunities you might want to have. We have all the links to the ORF committee members in different regions. So if you want to get in touch with the representative from Scotland or Yorkshire or Severn region, then please get in touch and we will pass on your details if you just want to reach out and ask some questions. We're going to move on now, I think, to the next part. So if I hand back, here we go, and I'll put myself on mute, but I'll be around for the Q&A at the end.
Okay, thank you so much, Mariam and Alex, for that wonderful overview and that enthusiasm. It's really, really great. So what we're going to do now is hand over to Abby. So for the last few years, the RCR has supported a fairer training fellowship, and we're really pleased that Abby's been one of the fairer training fellows. And you're going to share with us, Abby, a little bit about what you've been up to. So thank you very much.
Thank you. So the other hat that I wear, apart from being a registrar, is being a fairer training outcomes fellow. And I do work in a team. I have another clinical oncologist registrar who works with me on this fellowship, and there are other colleagues in the radiology side, and there's four of them. So in total, there's 6 of us, and we started in post back in 2022, and since then it's been quite a wild and wonderful ride. And today I'm just going to share a little bit about what we've done so far. So next slide. Before I go into this slide, actually, I'm just going to explain really what differential attainment is, because that underpins what this fellowship is about. So differential attainment is when you look at different groups, perhaps one has a protected characteristic, and you compare that to another group that does not have a protected characteristic, and then you note that there's a differential attainment. Basically, it's in the phrase, one group is doing less well compared to the other group for whatever reason, and it's unexplained. And this issue was what we were tasked to look at in this fellowship. Now, this slide just tells us how many people who come from ethnic minority backgrounds are in the NHS at large. So there's 41% of the medical workforce will identify as ethnic minorities. And this is not just on oncology, this is across the NHS. So it does make a big proportion. And then when you compare it to the population at large in England, in the UK, actually, ethnic minorities are overrepresented. So ethnic minorities make up about 13% or 14% of the population. So you can say that actually we're well represented, or even overrepresented in the NHS. Next slide, please. But this diversity, I guess, again, this is NHS-wide, and it's not just oncology that I'm talking about. But if you look across all the different specialties, all the different doctors that make up our workforce, ethnic minority doctors are underrepresented in consultant roles, in the more senior roles as well, such as clinical director, medical director. And ethnic minorities are overrepresented in other grades. So, for example, specialist, associate doctors, or the training grades as well. And this data is taken from, I'm just going to read it out because it's a bit of a mouthful. So the Medical Workforce Race Equality Standard. And this report came out in July 2021. So I would encourage you to read it. It, looks at the NHS body at large, and it does tell you the issues when it comes to differential attainment across the NHS. So next slide, please. Again, from the same report, they found that doctors who identify as ethnic minorities are less likely to believe that their trust provides equal opportunities for career progression. And next slide, please. And again, yet another sobering statistic or sobering data. CCT holders who identify as white are more or were more likely to apply for fewer consultant posts. They were more likely to be shortlisted for consultant posts, and they were more likely to be successful at being offered a consultant post. So next slide, please. So this is all very sobering data, and I guess it is helpful to set the scene of, where we are still at in the world. I guess we'd like to believe that everything is very equal and fair, but the reality is that it's not always the case, and it could be for various different reasons. And so what is important is to understand where the situation is at, because without doing so, we're not able really to identify solutions and implement them properly, because this is a topic that is important not only for us doctors, but eventually for the patients that we serve, really. And a culture of inclusion and psychological safety matters for doctors for obvious reasons, really. Not only does being feeling like you're othered, which is a term that some ethnic minority doctors have used to describe their experiences working in the health service. Number one, it's exhausting to feel like you're not being included. Number two, of course, it can have impact on career progression. And number three, actually, it's detrimental for patients if the staff is not feeling included, because they might not do what they need to do. If they're not progressing as they should, actually that diversity is not really being represented. And we know that patients are best served when they are seen or treated by doctors, again, across different grades, by workforce that actually represents them, also ethnically and culturally. So next slide, please. So this is something that the college is committed to making a difference in. We do embrace equality, diversity and inclusion. And it is something that I feel that as a college, we do very well, actually, compared to a lot of colleges. The GMC has tasked all colleges to look into this. But again, I'm not going to do any bashing, but I do feel from my interactions with people from other specialties that actually this is something that we're doing quite well. Next slide, please. So I've actually taken this sort of bit from the website, and you can go and have a look. We've just revamped our website, so it's very nice. So do take the time to explore. But some of the things that the college is committed to doing is monitoring diversity and making sure that we're not just having diversity for diversity's sake, but actually it's been reflected in all the different layers and levels of the college, from the consultant workforce, the trainee workforce, to the committees, the exam boards, etc. and etc. Making sure that the recruitment processes for all the various different departments is actually inclusive as well. And also gathering feedback. So not just thinking that you're implementing something and hoping for the best, but actually making sure that what you're doing, or what we are doing as a college, is achieving the required impact. So these are just a few of the things that we're committed to doing as a college. So next slide, please. So I'm a trainee, and I know certainly that this is true. So the trainee experience is impacted by different things. So, when we look at the topic of differential attainment, we can't just say, oh, it's the exams, it's, this particular thing. Actually, what makes my experience good or not so good is impacted by me, myself, and things happening to me, perhaps my own personal life, things that have been going on, my previous experience. My trainers, so this could include the consultants that I see on a daily basis and I go to clinic with. Also my supervisors, my clinical supervisor, my educational supervisor, my trainee program director, you know, the trainers at large, and also the environment that I work in. So what hospital am I in? What department? Who are my colleagues? Even allied health professionals. What is my rota like? And what do I have to go to for my peripheral clinic? So all these things impact on the training experience. So the reason why it's important to I guess look at this in more depth is that you can't just isolate one thing and focus, and you do have to have a rich understanding of the different factors that impact trainee experience and actually ultimately trainee performance. Next slide, please. So ultimately, this is what we are looking at. And you can see here a picture of the team. There's me with the afro. There's Susie to the right of the picture, right of me in the picture. And then the rest of my colleagues are the radiology trainees. And this is what we really wanted to look at. We do recognize that radiology and oncology are different specialties. And so we did have our own specific streams of work in oncology. And next slide. And so I've simplified this to some extent, but broadly, we wanted to look at two things. Firstly, we wanted to collect some data so that we could understand the situation a little bit better, and then look at interventions that we could do, because we knew we only had a good amount of time, but still limited to implement something and hopefully make an impact. So next slide. So when it came to data collection, what we did in 2022 was that we sent a massive survey to all the trainees in the college. So there's quite a few of them, I think over about 400. And we did get quite a good percentage of responses, so 140. And 26% of this cohorts that responded were international medical graduates. And that was actually quite important for us to ask quite a range of questions from, you know, how they were experiencing things, you know, whether they'd been able to pursue the opportunities that they wanted to. And there was an opportunity for them to even give us free text feedback. So quite a lot of rich data was collected at that point. And even to buttress this or to expand on this, we had a set of focus groups and interviews of trainees, SAS doctors, and also trainers, so that we could understand really differential attainment, how it is perceived amongst our own body, our colleagues, and what they thought could be potential interventions, things to make the situation better if they felt this was an issue. And actually, please do look out for the report. We're just in the process of finalizing things, and we'll be hopefully publishing this in the near future. And then you can see some of our findings. Having done this process and having sort of collected the data and seen it myself, I think that certainly there might be some issues. There were some issues amongst, you know, the body that we surveyed, and this is just us being honest. You know, we are committed to improvement. This is not us just trying to pat our back and say everything is perfect. But what was really important is that I actually think that we are doing well at the college. I think in terms of attainment, things could be improved in some aspects, perhaps, but by and large, for example, even I know I just said, you know, we don't look specifically at exams, but when we look at exams, actually the discrepancy is not as big as perhaps you see in other colleges, which shows that we as a college do well when it comes to inclusion and diversity and making sure that we achieve. But like I said, we recognize that we want to be good, we want to be perfect, we want to be the top, and we want to look at every single thing that we can to make the training experience the best possible for each and every trainee that comes through. So next slide, please. So in terms of interventions, we are doing quite a few things. Some of the things we do just for clinical oncology, some of the things I shared with radiology. And this was our first year, this was our pilot of doing things. So definitely we learned a lot during the process. For example, we were able to get people, trainees across the different nations who wanted to partner with us. We called them diversity leads, and they were really, really helpful to us, to be honest with you. Some of them joined us for our focus groups. You know, there was passion amongst this group. Some of them went on to present to their own hospitals and champion the cause a little bit. They all joined it for different reasons, but ultimately was a desire to look into this issue and whatever influence they had to be able to impact on it. And we had quite a great group, actually. They were from different ethnic backgrounds, you know, different gender, sexuality, different protected characteristics were really represented in this group. So it was really quite nice to work with them. At the moment, we are actually piloting the first reverse mentorship program. So reverse mentoring basically means that the trainee is the mentor and the senior is the mentee. And we've been doing this for the last 5 months or so, 4 or 5 months. And I think it's been going well. We've just collected quite a bit of the midpoint review feedback, and it seems to be going good. And our hope is that at the end of the pilot, which will be end of this year, early next year, we will be able to roll it out on a bigger scale. So this REAP project is one in collaboration with our radiology colleagues, and we're working with RadReach, which I will tell you about more about in a second. And it's basically, again, efforts to improve awareness of differential attainment and how to tackle it. Speed mentoring is another project in the works. And in general, one thing we're able to do on a great scale was really raise awareness. And I think one thing that I was really grateful for in this fellowship was the ability to have conversations and spark conversations about this topic. So we really didn't shy away from it. People didn't shy away from talking about it as well. And it just shows the commitment and really the culture of the college to make sure that our trainees are doing well, no matter what. So next slide, please. So RadReach, I just wanted to highlight RadReach. RadReach is a great initiative in the college, co-founded by some very amazing people. So I would encourage you to look into this. RadReach is for both the oncologists and the radiologists. It is a collaboration with the Widening Participation Network in medicine. So basically, they are committed to supporting trainees, you know, people who want to enter the specialty and even beyond, achieve. They help with things like interviews. So if you are interested and you would like to be a mentee, please look us up. Please look up RadReach and sign up, because this is exactly what they're there for, really. So we really do want to improve and increase our oncology representation. So this is something I'm definitely quite passionate about. So that's it for me, please. Next slide. Next slide. Thank you very much. And I did put my email at the top, but if you did want to email me and you didn't manage to catch that, it's just my name.my-surname @nhs.net. And I'll be very happy to get any questions now or later.
Thank you very much, Abby, for that overview. That's fantastic. So we're coming towards the end of the webinar now. I'm just going to share a little bit about how to apply. So if we could just go to the next slide, please. So we have had a few questions in the chat. So just to recap, then entry to clinical oncology recruitment is at ST3 level. You do, I think this was in the chat as well, you do need the Part 1 MRCP UK at the time of application and the full diploma by the offer date, or one of the other two equivalents there. If you want to find out about the full eligibility criteria and then any adjustments that might be made in the recruitment process, please go to the HEE website, and it's all there. There's a lot of detail in there. And just to say as well that the medical oncology application window and the offers are at the same time as clinical oncology. So you can apply for both, and then you can choose, if you get an offer for both, you can then choose which one you want, and that's deliberate. Could we have the next slide, please? So the recruitment timeline for the current application window. So the application window is now open. and it's going to close at 4 p.m. on Thursday, the 7th of December. You apply through the portal called Oriel, and again, it's all on the website again. And the evidence from your portfolio does need to be uploaded, and that's the application with the evidence upload window there. And there have been a few questions about how can you sort of increase your portfolio, improve your portfolio. So I think have a look on the website. Mariam did show what the criteria in the portfolio are. And there are some things that you can do. For example, teaching, or if you've been in a leadership role, or if you've done a quality improvement project, or you've done a presentation. So what I would advise for those that are thinking of applying in the future, just to try and get the evidence from that. So if you can get like a letter from your supervisor, or if you've done a presentation, the copy of the program or something like that, just so that you can upload that as independent evidence, and then that really supports your application. The interviews, so this is now for entry in August next year, but the interviews are in April, the 15th and 16th of April. And appointability is based on the interview. And there are questions on, there's a clinical station, there's an ethics and communication station, and then there's portfolio and experience station. The interviews are online, and the current procedure at the moment is that for each station you'll have 2 separate pairs of interviews. So you should overall get scored by 6 different interviewers to get your combined score. And then appointability is on the interview, and then the evidence from the verification score is then added to that to give the rankings. And then the initial offers will be released there in April. And there is the possibility for an upgrade then, because if, for example, I don't know why they would, but if somebody does turn down one of their posts, then you can, and that post becomes vacant, you can then be upgraded. So that can sometimes take a little while to do that. But it does mean that the whole process is fair, and that all the posts are appointed on ranking. So could we have the next slide, please? So that's just to say, these are all the people that have taken part today. So thank you very much to everybody. And we've also had Amy and Alison working very hard behind the scenes to keep the webinar going. Those are our email addresses. Please do contact us if you've got any further questions. I think there's been a lot in the chat, and I think Tom and others have done a fantastic job answering all the questions. So thank you very much for that. We did say that after the recording finishes, if there are any specific questions that haven't been answered, we are going to stay behind for a little bit to do that. But I think what we'll do now is we'll just draw the webinar to a close. Thank you very much again. Did you want to say something, Tom? You're on mute.
Yes, as always. Yes, thank you. Thank you everyone for joining, for being so enthusiastic in the chat. My arms are now tired of all the typing. 2 questions that I can't answer. Is there always a second round in July? I guess that depends on how well we feel first time round. Is that right, Louise?
So it does. We always have had a second round. It does depend on the number of posts, how well we filled. But because posts are coming up all the time, because people are getting their CCT all the time, even if we've had 100% fill rate, then we have always had a second round.
Thank you. And Amy or Alison, are we going to send out the link to this video to everybody, or will it just be on our website? Does anyone know how we're going to get that message out?
It will likely be uploaded onto the Choose Oncology web pages on the website.
There you go. So look at that within a day or 2, and it should be there ready. But if there are any questions after this, you've got all of our email addresses there. And as I hope you've got from this, we're all enthusiastic. We would love to hear from you if you've got anything else that you want to say.
And thank you very much again to everybody. Thank you all for linking in. And if you're applying this year, this time around, best of luck. And we hope to see a lot of you as our future colleagues. So we'll bring the webinar to a close, and thank you very much.